Thank you so much for the kind words. Honestly, very humbled and honored to speak to those that I serve, the people that I learned from and have over the last 35 years or so. And it's work in progress. This is a great meeting. You're going to learn a lot of things, but hopefully some of the things that I'm going to talk to you about today will not disturb you, but rather enlighten you. And my job here is not to tell you how rosy, how beautiful, how great, how wonderful it is, which in some cases it is. But my job is going to be to tell you about the good, the bad, and the ugly. I'm what they call a disaster doctor. I deal with disasters. And that's obviously very heartbreaking. And this is what makes it very, very difficult. And you will see in my discussion of why I think that the field has not done as well as it should and where it needs to move. And I feel very strongly about this. I do think that recognizing Pheochromocytoma Paragangliomas as being part of a family is something that is absolutely crucial. It's very important to be able to understand why. This is not somebody that we're trying to fit into a family. This actually is the truth. But I'm going to spend also a fair bit of time about why things are confused and confusing, particularly to doctors. So you can imagine, obviously, if they're confused, if they don't get it right, then there's a problem. And be careful about the term expert. An expert is only as good as the information being fed. And I will tell you right now, Justin did a great job on the genetics, but just want to tell you, it's recognized that in cancer in general, 1 out of 4 were not right. 1 out of 4 diagnoses. So imagine all of New England and the Lancet and Lancet Oncology papers. They're doing these wonderful trials. They're based on the premise that we take it at face value. We do wonderful analyses afterwards because we want to test the scientific validity, but it's based on acceptance that the fact to begin with is true and valid, when in fact, probably false in some cases. So that's why I think it's very important to be able to stand back. And there's no room for artificial intelligence here, unfortunately. So I'm going to walk you step by step. I'm not sure able to get it to move here, but are you able to? Let's do this. I'm going to show you this slide for a reason, and I don't expect you to be able to recognize it, but this is the architectural blueprint that every physician is taught and most clinicians forget. If you're going to renovate your house, you want your contractor to ask you first and foremost, show me the blueprints of your house. You're not going to start anything without that. This is my job. Just like a surgeon needs to know the anatomy really well, because Dr. Pasternak opens your belly and doesn't know where the major vessels and nerves are, you're in big trouble. Medical doctors, unfortunately, forget this stuff. And the reason why this is important, and again, I'm not going to go through the details as much as it tells me how the neuroendocrine cells came about, how close they are to each other, how they become specified, so that I know when they're in a different part of a body, how did this come about? And more importantly, when things are off, why are they off? We're going to talk in a minute, because everything you've been told so far tells you a Pheochromocytoma Paraganglioma is that in many instances, it's not just that. It's actually a composite. Sorry.
That's okay. You're fine.
I tend to be animated.
Yeah, I know. I'm happy about that.
This is telling you about the architectural plan in the body. It's telling you about where the cells are, how they came about, and more importantly, what this does is it gives us the lead so we can retrace the path. So that when we find disease somewhere in the body, we can say, not only what this really is, where did it start? Where is it going to go? What else is going on? So the genetics is one tool. It's one body of information. We need a lot more than that. We need the rest of the architectural blueprint. The second part is that I can actually apply that. And this is not only where clinicians don't get it, this is where most pathologists don't understand it. And that's a huge problem. Because guess what? In most hospitals in North America, they grab what they can out of the team of young pathologists and they say, you're going to do this. And they say, but I've never done this before. I have no idea what I'm looking at. Shut up. This is what you're going to do. And the less important your malignancy is, and I'm sorry, but that's the truth, the more likely you are to get dumped on to do the more esoteric stuff. And endocrine malignancies is one of those. So imagine for a second, you're trying now to get an expert paraganglioma pathologist to survive in North America in the Department of Pathology who's going to feed their experts to do the clinical trials and the wonderful research. But that little person who's never seen an endocrine malignancy, can't tell this from breast cancer, is having a very hard time poking to the holes of the problems they're facing. This is not acceptable. This is a huge problem. The dogma is, it's very obvious, don't worry about it. It's very simple. Everybody's going to come in with headaches, palpitations, sweating, diarrhea, and as Dr. Bordeaux mentioned to you, that's not only a fallacy, that's Disneyland medicine. It's not true. And you all know that. So beware. This is a patient that we see, and you can imagine what this tumor looks like. Nobody is going to be able to cure this patient. And not only that, but unfortunately, by the time that we got to see him, he's got bad kidney function. To begin with, he has thalassemia. He bleeds. He runs a hemoglobin well under 70%. And previous to that, he had a benign pheochromocytoma removed at a teaching hospital. This is in North America, 2025. These are the people who come into my clinic. I don't know why it's moving right now, but
I think because it's a video, so it
Oh,
just goes on.
okay. The other part I want to show you is and you're going to hear a little bit about the head and neck paragangliomas because you know that they're all over the place because that's where the nerve bundles are. I call them the penthouse main floor in the basement. Beware, you don't want to be in the penthouse for sure because when you get one of those tumors at the skull base, it messes up your cranial nerves. You can't swallow, you can't chew, you can't breathe, and you aspirate and you get into a lot of trouble. Maybe she can try to slow it down.
I'm not,
Okay.
it's just a recording, so it'll
Okay.
just play on its
All
own.
right. So the paraganglioma, really, the first thing that you want to know is it pure or is it mixed? So here's going to be one of the problems. If your doctor says, I don't know. And if it's mixed, is it mixed with a cognet, a paraganglioma, the ganglioneuroma, a neuroblastoma, schwannoma? There's a whole bunch of other tumors. So if you stick a needle in or if you take part of it, did you get the good part, the bad part, the in-between? You have no idea. It's a very big problem. Watch out for some of the areas where people are going to tell you, you got a metastasis in your ear. It's not a metastasis. This is a primary neuroendocrine tumor of the middle ear. That's an entity in and of itself. There are also primary cauda equina, tumors of the spinal cord that impair your bladder and kidney function arising just from that part. And that patient will be written off. It's not a metastasis. So you really do need to know what you're doing, and you really need to know at the fundamentals, because that's what's going to drive the scans, the blood tests, the hormone studies, the genetics. All of that is contingent on the blueprint. Remember what I showed you earlier? You got to get your ABCs right. Hugely important. And fundamentally, the question has to be answered from the very beginning. Are you dealing with multiple primaries or metastasis or possibly both? And unfortunately, radiologists don't know that. In fact, they'll look at multiple paragangliomas, they'll say there is lymphadenopathy. Well, I challenge my radiologists all the time, Dr. Pass, and I will tell you that they're superimposable anatomically on a CT or MR. No one, and I mean no one, can tell the difference between a lymph node and a paraganglioma. They're superimposable. And unless you histologically take out a so-called lymph node and show that there are lymphoid elements and paraganglioma, you cannot make that diagnosis. The same applies to bone. And we have many such examples in our institution. So how your doctor answers are going to be very, very important. I am an international expert, so don't question me. I know everything. That's one possible answer. Or I don't know the answer, but I have no idea what you're talking about. Or possibly at my institution, I have some people who might be able to give us an answer, or this is a reasonable thing, let's try and figure it out. You pick the one you think is more relevant. So the key to most effective management of any kind, not only is it early detection, but it's also knowing that the information is valid. And you've seen this, and I'm going to try and just make it very simple. This is your electrician. And this is the second part where a lot of medical students study it very hard, and then they forget it when they start practicing medicine. This is called hardwiring. How does information from outside the cell ultimately get through and into the DNA to tell the cell whether it's going to live, die, or multiply? Okay? It's very simple. It really is not rocket science. In fact, it's a lot simpler than that. But the actual steps, the so-called engaging signals from the outside to inside, is what we call cell signaling. And the genes that you heard about before are the ones that are emerging in our ability to be able to say, okay, this is where the problem is, that this is a cell that has gone rogue because now it's thinking there isn't much oxygen around. So that's what we call pseudo-hypoxia, that's the term. And we know what the players are, and we've got drugs that are already developed that can target this area. So this is how we're going to do it. That's how medicine was in the last century. In the last century. We need to be much more than that. We're in the 21st century now. So this was good. It was great. But I would tell you it's not good enough. We can do a lot better than that. There's a lot much better techniques than that. The criteria of malignancy, as I told you, is very, very difficult. And simply put, there are two criteria that you need to meet. Number one is there evidence of paraganglioma in a place that does not have paraganglioma tissue normal? And when you take out the tissue, there is such a thing as what's called a sustentacular cell. Sustentacular cell is a modified neuron that locally provides the soil for the tumor to grow. And if you find that, then you nail that this is a primary tumor at that site, not has spread to it. Look at the patient. This is a patient who has a condition that we can recognize very quickly. Dr. Pasternak, I recently had such a patient. You walk in, you ask them, look in their mouth. I hate this going so fast. I apologize. But we can tell these syndromic. We can tell actually. So look at the patient, listen to the patient, and bring it back to what you learned in medical school. Please, please. There was a reason why they taught all this stuff to us. We can use drugs. And I'm going to show you an example of a story that we were involved in going back to 2009 of a drug discovery. And I just want to show you the story, not because it was a great story, because it was a true story. At the time, and I think Dean, you do some GU stuff as well. So we had these patients who were coming in who had large kidney cancers, as you can see here in the scans, and we were treating them with a drug. And the important thing is that some of them were beginning to feel very unwell, but the tumors were shrinking. And it was happening in the abdomen, and you can see the chest again, the CTs were showing wonderful job, and we were so happy, except for one problem. When we took out the tumors after we shrank them, we did a wonderful job. They didn't have kidney cancer. Those were paragangliomas. And that's how we made the discovery. We went back and we forced ourselves to really reissue. And that's how the story of the use of Sutent in paraganglioma started. It was from a wrong discovery based on wrong information, but we were stubborn enough to be able to say, that doesn't make sense. We challenged ourselves. And I think that's what's important here. So I'm going to let this work out very quickly here. The bottom line is we've got drugs, we've got therapies, we've got RFAs, we've got embolizations, we've got a lot of tools. I firmly believe that a patient with paraganglioma, Theo, has to be managed in a cancer program. And I don't know whether some of you here agree with me or not, but there is no reason why a paraganglioma patient should be considered anything but. The resources that are there, from the testing to the imaging to the interventional approaches to the pharmacotherapies, all should be part of that broad platform. And if you're a patient and you've had breast cancer, and God forbid later on you then develop a paraganglioma for whatever reason, you should not be treated any differently. And the access to resources and expertise should be just the same. Whether it's syndromic or not, you are a human being. You pay your taxes, you're equal to everybody else. There is no reason why you should be second tier. And I actually believe that this is going to help the medical community as well, because instead of struggling, and this is my really plea, Linda, and to others back in the United States, just as much as it is in Canada, no area of medicine will ever survive on its own when it's a very small niche, because you do need that infrastructure. You need the support. You need the DNA testing we do right now involves 500 genes, not 10 or 12 or 15. Why? Because that's what we offer our prostate patients, our lung patients, and Dean will tell you the same thing. He practices other areas of cancer. This is the reason why I truly believe that there are newer therapies that are coming up. Those therapies are accessible and available, and they potentially have their place, but it's only as good as the quality of the information that we're putting into this. My take-home message is newer imaging, biologics, radiopharmaceuticals, these are all great, but we need to move away from the traditional classic 20th century endocrinology, which is traditionally where paragangliomas have been, and we need to move them into the 21st century. Invite our medical oncology team, our surgical oncology team, our surgeons, everybody has to come in, because this is how medicine should be practiced and not be given just simply to chance. I hope I've given you some idea of what the possibilities are. And I hope I've also told you that when I sign off on a patient and I tell them you're going to be fine and you're good and you're not going to be in trouble, it's because I have valid, solid information from the other patient. I'm saying, hey, come back here. One last point I want to emphasize, and I bring you to the New England Journal from last week. There was a paper specifically on the risk of cancer related to imaging. Comes up all the time. And you saw it even earlier. I think one of the slides said, do MRIs, because CT is dangerous. CT scans in the current era have lower dose of radiation. You're in and out in less than 10 minutes. CT is a fantastic medium. We can do it. Please don't be shy and don't do this 3 to 5 year story. My view, that's suboptimal. Get your CT done. Do it. Do it because you buy insurance, not because you get into trouble, but because you want to avoid trouble. So I hope I've left you with some concrete messages. I know not everybody agrees with me, and that's why I'm here, not over there. That's okay. I think the key point, though, is we need to be honest with each other, and it is a community. And when we talk about having to work as a team, it really has to be a true meeting of the minds. Thank you.